Welcome to the Deep Dive. Today we're taking a close look at hyperbaric oxygen therapy, or HBO, specifically its role in wound healing, plastic surgery, and dermatology.
Right. We've pulled together quite a bit of medical literature on this.
Yeah, and the idea is to really dig into how, boosting oxygen levels can impact different tissue conditions, injuries.
Exactly. We want to explore how putting someone in pure oxygen under increased pressure can actually be a useful tool in medicine.
So maybe define it quickly. HBO therapy is basically,
It's breathing 100% oxygen inside a special pressurized chamber. Think of it like being maybe 10 feet underwater pressure-wise, but you're breathing pure O2.
gotcha. And our mission for this deep dive.
Is really to understand the how and the why it's used. We'll pull out the key insights, maybe some surprising facts, but also keep it real about its potential and its limitations.
Okay, sounds good. Let's start with the basics then. How wounds normally heal and where oxygen fits into that whole picture.
Right. So a wound is basically any break in our tissues. Could be a cut, could be something causing tissue loss.
And an ulcer, that's a specific type.
Yeah, think of an ulcer as more of a localized defect, like a crater, often on the skin, or maybe an organ lining. It happens when dead, inflamed tissue sloughs off. If it's on the skin and goes through both the top layer, the epidermis, and the dermis below, that's an ulcer too.
Okay, and normal healing. It's not just scab and done, right? It's complex.
Oh, very complex. It's quite a sophisticated sequence. First, you get platelets and this protein fibrin rushing in to stop bleeding.
Initial plug.
Exactly. Then come the macrophages, they're like the cleanup crew.
Yeah.
And then fibroblasts, smooth muscle cells, endothelial cells. They all start showing up.
And they communicate.
Yeah, they release these signaling molecules, cytokines. Think of them as messengers telling everyone what to do. Grow here, repair this.
Okay, so organization, communication, then what?
Then you get angiogenesis, that's a new blood vessel formation, really crucial. Plus collagen production, the stuff that gives tissue its structure.
Right, the scaffolding.
Precisely. The wound fills up with this stuff called granulation tissue, and eventually the original cells come back, and ideally, it's healed.
And oxygen. Where does it fit in all that? Is it just fuel?
It's way more than just fuel, although it is that too. It's a vital nutrient for the whole process. It actually helps regulate how fibroblasts multiply.
The collagen factories.
Yep. And here's a key point. Oxygen is absolutely essential for modifying amino acids, proline, and lysine specifically. This modification has to happen for fibroblasts to release collagen properly and for that collagen to actually link up and form strong tissue.
Ah, so without enough oxygen, weaker repair.
Definitely a weaker repair, no doubt about it.
Okay, now you mentioned something interesting in the prep, that low oxygen hypoxia can actually start the process.
Yeah, it's a bit paradoxical, isn't it? But that temporary local shortage of oxygen, which happens with almost any injury, seems to act as an initial trigger.
How so?
Well, those macrophages, the cleanup crew, under low oxygen conditions, they produce a factor that actually encourages new blood vessel growth, angiogenesis.
So the initial stress kicks things off.
It seems that way, but, and this is crucial, after that initial trigger, you absolutely need a sustained supply of oxygen to keep the healing going properly. You need those new blood vessels to deliver it.
Which leads us nicely into the problem of wounds that don't heal, chronic wounds.
Right. And this is a huge public health concern. We're talking wounds that just won't close up despite standard care. The cost is massive, billions in the U.S. alone.
What kind of things lead to these non-healing wounds?
A whole range of conditions. Poor circulation in the arteries, so arterial insufficiency. Diabetes is a big one. Cancer, infections, even psychological stress can play a role. Oh, and using corticosteroids.
But often there's an underlying issue with oxygen.
Very often. Hypoxia, low oxygen, and ischemia-reduced blood flow are major factors. When tissue is starved of oxygen, you get an energy crisis right at the wound site.
And that impacts everything we just talked about. Collagen, cell movement.
Exactly. Collagen synthesis suffers, and what is made might be weak. Fibroblasts, those key repair cells, they don't migrate well if oxygen drops too low, say below 10 millimHg or so.
And if it drops to zero, anoxia.
Well, then you get a buildup of waste products, cells can swell. It just completely stalls the process.
So ischemia causes hypoxia. But you can have hypoxia without ischemia.
Yes, that's an important distinction. For instance, if you have a nasty infection in a wound, Even if the blood supply is okay, the bacteria and the immune response can just gobble up all the available oxygen, creating local hypoxia.
Okay. Now, before we jump into HBO specifically, there are other ways to treat tricky wounds, right?
Oh, absolutely. Standard care involves things like keeping it clean, dressings, maybe skin grafts, and there are newer things like growth factors or bioengineered skin substitutes like Apligraf.
The HBO is often used in addition to those as an adjunctive therapy.
Precisely. It's usually part of a broader treatment plan, not typically a standalone fix for these complex wounds.
Right. So let's get into it. How does putting someone in a pressurized oxygen chamber actually help these wounds heal? What's the rationale?
Okay, well, the core idea, the most obvious one, is that it directly fights the hypoxia.
By forcing more oxygen into the blood.
Exactly. Breathing 100% oxygen under pressure dissolves much more oxygen directly into the blood plasma, not just what binds to hemoglobin. This super-oxygenated blood then circulates and delivers more oxygen to tissues, even those with poor blood supply.
And the pressure level matters.
It does. Higher pressure means more dissolved oxygen. Different protocols use different pressures, like 2 atmospheres, 2.4 atmospheres. Depends on the condition.
Okay, so it corrects the main problem.
Yeah.
Lack of oxygen. What else?
Well, it's not just for severely hypoxic tissue. Even in tissue that's just inflamed but might have decent blood flow, HBO can improve oxygenation. Inflammation itself can kind of create barriers to oxygen diffusion.
Okay. And what about those fibroblasts we mentioned, the collagen makers?
There's evidence that repeatedly boosting the oxygen supply, like with intermittent HBO sessions, actually stimulates fibroblasts to replicate more and produce more collagen. They seem to like these oxygen boosts.
Interesting. And you mentioned something about the RNA-DNA ratio.
Right. Improved oxygen supply tends to increase the RNA-DNA ratio in the tissue. You can think of that as a sign that the cells are becoming more active, more specialized, gearing up for repair.
Like they're reading the repair manuals more actively?
Something like that, yeah. And a really big one, fighting infection. Higher oxygen levels significantly boost the ability of our white blood cells, the leukocytes, to kill bacteria. That's huge in wound care.
We did cover that before, yeah, killing bacteria.
Plus, healing tissue just needs more energy, more oxygen. HBO helps meet that increased demand.
Okay, so better oxygen supply, better cell function, better infection control. What about the actual structure of the healing?
It promotes epithelialization, that's the skin cells growing back over the surface, especially in wounds with poor blood supply. And maybe most importantly for long-term healing, it promotes neoangiogenesis.
New blood vessels again?
New blood vessels, absolutely vital. So you see, HBO helps this whole cycle. More oxygen lets the cells at the edge move further in, make more stuff, build new vessels. It accelerates the whole closure process.
Have studies actually shown stronger wounds?
Some experimental ones, yes. Wounds exposed to hyperoxygenation early on, like in the first week, showed increased strength. But there's a caveat.
Which is?
Prolonged exposure beyond what's needed might actually slow things down. So it's not just blasting it with oxygen indefinitely. It needs to be targeted.
Right. Moderation in all things, even oxygen.
Kind of. And
Yeah.
interestingly, it also seems to help reduce damage in things like frostbite, these cryobiologic wounds.
Okay, but we don't know every single detail of how it works at the cellular level yet.
No, definitely not. The exact cell interactions, the precise molecular mechanisms that's still being actively researched, like how it affects proteins involved in the hypoxia response, like HIF1A. We see the good results, but nailing down every step biologically is ongoing work.
Fascinating. Now, you mentioned something else playing a role. Nitric oxide. And no.
Yes, nitric oxide. That's another really interesting piece of the puzzle.
How does it fit in?
Well, studies suggest HBO might boost wound strength and that crucial angiogenesis partly through the nitric oxide signaling pathway.
So HBO makes the body produce more NO where it's needed.
It seems that way. There was a preliminary study on chronic wound patients who were responding well to HBO. They found higher levels of NOx-stable breakdown products of NO right there in the wound fluid.
And that correlated with healing.
It did, yeah. Higher NOx levels lined up with better wound reduction. Interestingly, though, the precursors for NO production in the blood didn't really change.
So it's a very localized effect within the wound itself.
Looks like it. But again, balance is key. No production is transient. You need it for healing, but too much NO can actually hinder things. It's a delicate interplay.
Biology is rarely simple, is it? Okay, let's shift slightly. What about healing that's impaired not just by physical factors, but by something like psychological stress?
That's a really important connection. We know stress negatively impacts wound healing. Studies in both humans and animals show this.
How does stress do that?
It triggers physiological responses, think fight or flight, that can constrict blood vessels. Less blood flow means less oxygen getting to the wound. Combine that with the fact that stressed tissue might actually need more oxygen, and you've got a recipe for slow healing.
But HBO can help counteract that.
It seems so. A mouse study showed that giving HBO early on significantly reduced the negative impact of stress on healing rates. It brought them almost back to normal non-stress levels.
Did it help the non-stressed mice too?
Interestingly, no. It didn't have much effect on the control group without stress. It really seemed to target the stress-impaired healing.
And is nitric oxide involved here too?
Looks like it. The researchers looked at an enzyme called ionose-inducible nitric oxide synthase, which makes NO. Stress seemed to increase ionose activity in the wound.
At HBO.
HBO treatment decreased that stress-induced ionose activity. So the thinking is that by boosting tissue oxygen, HBO might help normalize NO production that's been thrown off by stress, offering a way to combat stress-impaired healing.
Wow. Okay, so HBO tackles low oxygen from various causes, poor blood flow, inflammation, even stress. Now, practically speaking, how do clinicians know if it's actually working? How do they measure the effect?
Good question. Monitoring the actual oxygen levels in the tissue or near it is key.
How do they do that? Is it invasive?
Often, they use a non-invasive method called transcutaneous oxygen pressure measurement, or TCPO2. They place sensors on the skin around the wound.
Not directly on it.
Usually not directly on the open wound, no. But the levels measured nearby correlate pretty well with healing potential.
Are there target numbers they look for?
Yeah, there are general guidelines. If the TCPO2 is above, say, 20 millimole Hg, just breathing room air, that suggests the patient is likely to respond positively to HBO.
And when they get oxygen?
Ideally, that number should roughly double, just breathing 100% oxygen at normal pressure, and then jump up significantly more, maybe to around 100 millimole Hg or higher, when they're breathing 100% oxygen at 2 atmospheres inside the chamber.
So it shows the tissue can take up the extra oxygen being delivered.
Exactly. It assesses the tissue's responsiveness. There was an interesting study on wounds with a lot of swelling, edema.
What did that show?
It showed that the TCPO2 increased quite dramatically during oxygen breathing and HBO. This suggested the swelling itself was acting as a barrier to oxygen getting through under normal conditions.
And did HBO help the swelling?
It did, yeah. The study found HBO significantly reduced the swelling around the wounds. So it might be tackling both the oxygen supply and a physical barrier.
That's a double benefit.
Yeah.
But are these TCPO2 measurements foolproof predictors?
Not entirely. While they showed correlations in that edema study, single measurements alone weren't perfectly predictive of how much the swelling or the wound itself would improve.
So helpful, but not the whole story.
Correct. And another analysis, this one looking back at lots of diabetic foot ulcers treated with HBO, found something similar. The TCPO2 measured inside the chamber was somewhat predictive, but it was more reliable if you combined it with the TCPO2 measured breathing normal air outside the chamber. For example, a really low reading in room air, plus a reading that didn't jump up very high inside the chamber, was a stronger sign that HBO might not work for that patient.
Okay, so looking at the baseline and the response gives a better picture. Makes sense. Now, way down at the cellular level, what's the absolute minimum oxygen needed for those energy factories, the mitochondria, to even work?
It's surprisingly low for basic function, maybe only 0.5 to 3 millimole Hg for oxidative phosphorylation.
There's always a but.
Yes. The activity of a key enzyme, cytochrome C, starts dropping off as oxygen levels fall, and it's significantly impaired below about 30 millimole Hg.
But it can recover if oxygen comes back up.
Thankfully, yes, those changes are reversible. But since that energy production is fundamental for repair, keeping oxygen above those critical thresholds is vital for healing to happen at all.
Right. Got it. Okay, let's pivot now to specific types of wounds where HBO is used. How about ulcers caused by artery problems? Arterial insufficiency ulcers.
Okay. These happen because the arteries aren't delivering enough blood, usually to the legs or feet. Studies have shown HBO, typically at 2 to 2.5 times normal atmospheric pressure, can relieve pain and promote healing in some patients.
Any specific conditions respond better.
It seems particularly helpful in a condition called thromboangiitis obliterans, and also in arteriosclerosis, though that might require longer treatment courses. Response can also be dose-dependent. Some need more pressure or more sessions than others.
Could it help prepare the wound for something like a skin graft?
Yes, that's often mentioned. By improving the oxygenation and cleaning up the ulcer base, it might make it a better bed for a graft to take.
Interesting. Any other types of arterial ulcers where it seems particularly effective?
Anecdotally, ulcers caused by rheumatoid vasculitis seem to respond quite well. And one study highlighted a specific marker. If HBO could raise the skin oxygen pressure in the foot above 100 mmHg, those patients tended to heal completely.
A clear indicator. What about overall success rates?
One review, looking back at patients whose arterial ulcers hadn't healed with standard care, found HBO led to healing in about 44% of cases.
That's pretty significant for difficult wounds.
It is. And crucially, in the group that healed, the amputation rate was 0. In the group that didn't heal, it was over 40%.
Wow, that really drives home the limb-saving potential.
It does. But as the researchers noted, we still need more high-quality prospective studies to really solidify these findings.
Fair enough. Okay, let's tackle a really big one. Diabetic ulcers, especially diabetic foot ulcers or DFUs.
Yes, DFUs are a massive problem, very common, often resistant to standard treatment, and a huge risk factor for amputation.
Why are they so hard to treat?
It's a complex mix. Diabetes damages both large and small blood vessels, leading to poor circulation. It also causes nerve damage or neuropathy, so people might not feel injuries. Plus, high blood sugar can impair immune function, making infections more likely and harder to clear. It's often called diabetic foot syndrome.
A perfect storm,
Pretty much. Standard care involves meticulous wound care, tight blood sugar control, treating infections, and newer options like those skin substitutes or growth factors we mentioned.
So where does HBO fit in for DFUs?
The thinking is it can help combat the hypoxia, the swelling, and the infection components. But, and this is important, it doesn't fix the underlying nerve damage.
So you still need comprehensive diabetic care.
Absolutely. And before even considering HBO, you need a good vascular assessment. Can blood flow actually get the extra oxygen to the area? And those TCPO2 measurements are crucial to see if the tissue can respond.
Is there a target oxygen level for diabetics? I remember you mentioned a very high number earlier.
Yes, there's a concept that for optimal healing in some diabetic wounds, you might need to push the tissue oxygen really high. Some suggest if you can't get the PO2 up towards 1,000 mmHg during an HBO challenge, it might indicate severe microvascular disease, meaning HBO is less likely to help.
1,000, that's incredibly high.
It really highlights the circulatory challenge in some cases. Researchers are also looking at other ways to boost healing alongside HBO, like endothelial progenitor cells, EPCs.
Stem cells for blood vessels?
Kind of, yeah. They help build new vessels, but their numbers are often down in diabetes. HBO seems to help mobilize more EPCs from the bone marrow.
But they need to get to the wound.
Exactly. And diabetes can also reduce a signaling molecule, SDF1A, that helps them home to the injury site. So there's research into maybe applying SDF1A to the wound to help the HBO-mobilized EPCs find their target.
Combining approaches.
Yeah.
Makes sense.
Yeah. Animal studies even suggest HBO triggers stem cell release via a specific enzyme, NOS3, without causing a big spike in white blood cells, which could be problematic. And these mobilized cells seem packed with factors that promote vessel growth.
So, turning to the clinical studies on HBO for DFUs, what's the verdict? Is it consistently effective?
It's mixed. The literature, as summarized in tables like 16.4 in our source material, shows varying success rates and different treatment protocols being used. Some studies, like those by Falia and Oriani, reported really impressive results, significant reductions in major amputations in the groups receiving HBO.
And others?
Others have shown less dramatic benefits or have faced methodological criticisms like high dropout rates. It's not uniformly positive across the board. Severity matters too. The Wagner scale grades DFUs from 0 to 5.
And HBO is generally for the more severe grades.
Typically, yeah. Wagner grade 2 involves ulcers reaching tendon or bone. Grade 3 adds infection or abscess. Grade 4 is gangrene of part of the foot. HBO is usually considered for grade 3 and definitely for grade 3 or higher, often after initial surgical cleaning. For grade 4, it might help limit how much tissue needs removal. Grade 5, whole foot gangrene, usually means amputation anyway.
What do the official guidelines say? Like from the Undersea and Hyperbaric Medical Society, UHMS.
After reviewing the evidence, the UHMS guideline recommends HBO for Wagner grade 3 or higher DFUs, either after surgical debridement or if they haven't improved after at least 30 days of good standard care.
But not routinely for less severe ones, like grade 2.
They found insufficient evidence to support routine adjunctive HBO for grade 2 or lower DFUs, so it's targeted at those more complex, non-healing, severe cases.
But even then, there are critiques.
Oh, yes. Organizations like the Cochrane Collaboration have reviewed the DFU trials. They concluded that while HBO seems to improve healing in the short term, the quality of many trials is lacking, raising concerns about bias and the reliability of long-term results. They call for larger, better designed trials.
So cautious optimism, but more proof needed.
That's a good summary. Other reviews echo that some evidence of effectiveness, especially if there's also poor blood flow, ischemia, but we need more robust data before it becomes a standard recommendation for all such patients.
And what about the cost? HBO isn't cheap.
Definitely not. A full course can run into tens of thousands of dollars. The argument for it economically is that by preventing amputations, it might save money in the long run, avoiding surgery costs, long hospital stays, rehab, prosthetics.
But does the evidence always support that cost effectiveness?
Not unequivocally. There was a notable study from Orlando, actually, that had quite disappointing results. Very low healing rates for various problem lower extremity wounds, including DFUs or treated with HBO, and a surprisingly high rate of barotrauma ear or sinus problems from the pressure. That study really questioned the routine use and cost effectiveness for these wounds.
So the jury is still somewhat out on the broad application for DFUs.
I think that's fair to say. There's ongoing need for those big, international, well-run randomized trials, and the focus needs to be on limb salvage, the big picture, not just ulcer healing rates. Plus, we have to remember that things like advanced skin substitutes and maybe even cell or gene therapies are developing rapidly as primary treatments for the ulcers themselves.
Right, a complex and evolving field. Okay, let's switch gears to venous ulcers. Different cause, right?
Completely different. Venous ulcers or stasis ulcers are due to problems with the veins not returning blood effectively from the legs. Chronic venous insufficiency, or CVI.
So blood pools in the legs.
Essentially, yes. High pressure builds up in the veins, often due to faulty valves, maybe from past clots or varicose veins. This pressure gets transmitted to the tiny capillaries in the skin.
And that damages them.
It leads to microangiopathy changes in the microcirculation. Capillaries can get enlarged, leaky, some might even disappear. You can get microclots, swelling, skin changes like discoloration, thinning, and eventually ulcers form, typically around the ankles.
So it's a drainage problem causing skin breakdown. Is oxygen a primary issue here?
It's debated. Skin oxygen levels can be low superficially, maybe because of swelling or changes around the capillaries. One theory talks about fibrin cuffs forming, blocking diffusion. But deeper tissues might actually have increased blood flow, paradoxically. Chronic inflammation involving neutrophils also plays a big role.
How are these usually treated then?
The cornerstone is compression therapy bandages or stockings to help push the blood back up the leg. Elevating the legs helps too. Plus, good wound dressings. Sometimes surgery to fix the underlying vein problems. There are some medications, and again, Apligraf, the bioengineered skin, is approved and can help heal them faster than compression alone.
So where does HBO fit in if oxygen isn't clearly the main villain?
Well, the rationale is often based on that hypoxia theory, even if it's not fully proven as the cause. Some studies have shown venous ulcers improving with HBO, either systemic or topical. Combining it with skin grafting seems to boost effectiveness.
Is it standard practice?
Not really first line. Compression is key. If an ulcer isn't healing, Apligraf is often considered primary. HBO might be a supplementary option, maybe to help a graft take, but it's not as established as for, say, severe diabetic ulcers or arterial issues. More research needed, again.
Okay, makes sense to focus on the primary venous issue first. How about decubitus ulcers pressure sores?
These are caused by prolonged pressure cutting off circulation, usually over bony spots like the hips or tailbone, common in people with limited mobility.
What makes them worse?
Poor hygiene, malnutrition, general frailty, they all contribute. The pressure causes ischemia, skin breaks down, bacteria invade, you can get inflammation, microclots. They become chronic wounds.
Can HBO help these?
Some early studies using topical oxygen, high concentration oxygen at normal pressure applied to the wound, showed some benefit. Reduced inflammation, new tissue growth, however. Current guidelines, like from NICE in the UK, generally don't recommend routine HBO for pressure ulcers. There might be specific cases, like heavily infected sores or ones involving failing surgical flaps where it could be considered adjunctively, maybe to prepare an infected bed for a skin substitute. But honestly, the absolute most important thing with pressure ulcers is prevention.
Right, preventing them is far better than treating them.
Yeah.
Okay, a quick word on infected wounds in general in the context of healing.
We covered infection treatment in depth before, but related to wound healing, HBO is definitely something to think about if you have an infected space that just can't get good blood supply, even after cleaning it out surgically and maybe trying a flap. Infected ischemic ulcers, those with both infection and poor blood flow, often respond positively to HBO.
Because it boosts oxygen for the immune cells and fights the ischemia.
Precisely. Okay, how about something totally different, frostbite?
Injury from extreme cold. How does HBO help there?
Frostbite damage comes from the freezing itself, ice crystals in cells, but also hugely from the vascular chaos during rewarming. Blood vessels constrict, clots form, there's swelling. It's very similar in
Can paradoxically cause more damage.
It can, through inflammation and other processes. Standard treatment involves rapid rewarming, maybe drugs to dilate vessels or thin the blood, careful wound care, and often waiting to see how much tissue survives before removing anything.
In HBO.
It's reported as useful in limiting tissue loss and speeding healing. Case reports describe saving limbs that looked doomed. It seems to counteract the hypoxia and edema, promote healing, maybe prevent infection, and help clearly define the line between dead and viable tissue.
Is the evidence solid?
Well, like many HBO applications, large controlled trials are lacking. Animal studies are mixed. But the rationale is strong, and it's often used when ischemia persists despite other measures or if surgery is needed for deep tissue defects.
Okay, another unusual one. Brown recluse spider bites.
Yeah, these can sometimes cause nasty ulcerating wounds, though often they're minor. The venom has an enzyme, sphingomyelinase D, which HBO is thought to counteract.
How?
The exact mechanism isn't perfectly clear. Animal studies show HBO given within a couple of days reduces the size of the resulting lesion, maybe by affecting white blood cell activity locally, though not necessarily by increasing blood flow. Human case reports suggest it can help people recover without needing surgery, even if started a few days post-bite, so it might help avoid more invasive treatments.
Interesting. Now, shifting completely inflammatory bowel disease, IBD, specifically refractory perineal Crohn's. That seems way outside wound healing.
It does, but there's a connection through inflammation and potentially compromised tissue health. IBD involves chronic gut inflammation. Perineal Crohn's disease, affecting the area around the anus, can cause very difficult-to-treat fistulas and abscesses.
And standard treatments don't always work.
Exactly. Anti-inflammatories, immunosuppressants, biologics, surgery, sometimes they fail. HBO has emerged as a relatively safe option in these refractory cases.
How might it help? Anti-inflammatory effects.
That's the thinking. Studies have shown not just clinical improvement, but also reductions in inflammatory markers like cytokines IL-1, IL-6, TNF-alpha during HBO treatment in these patients. Systematic reviews show pretty good overall response rates for refractory perineal Crohn's.
So potentially calming the inflammation and improving tissue health in that area.
Seems to be the idea. Still needs more research on optimal protocols and use in less severe cases, but it's a promising avenue for a very challenging condition.
Okay, let's bring it back to surgery now. Skin flaps and grafts. You mentioned HBO helps them survive.
Yes, this is a really important application in plastic and reconstructive surgery. Moving tissue around, whether it's a flap still attached by a stalk or a completely free graft, always carries a risk the tissue won't get enough blood supply ischemia.
And if it doesn't get blood, it dies.
Right. Flap failure is a major complication. Free grafts start out with basically no blood flow and rely on new vessels growing in, so they're very vulnerable initially. Ischemia and reperfusion injury with those damaging free radicals are big culprits in flap necrosis.
So what happens in an ischemic flap?
It's a cascade. Cell membrane pumps fail, inflammation kicks in, free radicals increase, you get edema, energy stores, ATP deplete. Eventually, cells die, tiny blood clots can form. It's a downward spiral. Tissue hypoxia is the common theme.
And HBO directly counteracts a hypoxia.
Exactly. That's the primary benefit. Animal studies are pretty consistent here. HBO significantly improves survival rates of various types of flaps and grafts, especially if started early after surgery. Delaying treatment makes it less effective.
Does it help the donor site heal too, where the graft was taken from?
Yes, studies show faster healing of donor sites as well.
You mentioned some differences between rat and pig studies.
Yeah, mostly due to the different vascular anatomy of the flaps typically used in those models. Rat flaps often have muscle, pig flaps are more skin only. But the overall conclusion across models is that HBO helps compromised flaps.
How else might it be working besides just delivering oxygen?
It seems to improve microcirculation, increasing the number and size of small vessels, improving flow to the edges. It might enhance protective antioxidant enzymes, maybe inhibit damaging enzymes involved in reperfusion injury. There's even synergy shown with growth factors like VEGF.
What about human clinical results?
Clinical experience and studies show reduced flap failure rates with adjunct HBO, better survival area for split-thickness grafts. It's even allowed surgeons to use thicker grafts sometimes. It's valuable in severe burns in kids, enabling earlier grafting. Successful ear reattachments, complex jaw reconstructions with microvascular flaps, all have benefited from adjunct HBO.
Are there predictors of success?
One review found that patients who completed more HBO sessions and had higher pre-treatment TCPO2 levels tended to have better outcomes with failing flaps. It's also used during tissue expansion to improve blood flow and skin growth.
So overall, the mechanisms seem to involve relieving hypoxia, improving microcirculation, reducing metabolic problems and reperfusion injury, and speeding up granulation.
That sums it up well. Indications are usually significant ischemia or hypoxia, grafting into radiated tissue, or previous graft failure. Starting within 24 hours post-op is generally recommended, typically 2.4 ATA, 90 minutes, twice daily for maybe 3 to 10 days, but it varies.
Hard to do perfect placebo-controlled trials in these situations, I imagine.
Very difficult given the variability of wounds and flaps.
Okay, last major application, thermal burns.
Burns cause direct tissue death from heat, but also massive inflammation, vessel dilation, leakiness, swelling. The skin barrier is lost, increasing infection risk. And the initial ischemic damage can actually worsen over the first few days.
So secondary damage is a big problem.
Huge. For deep burns, standard care is cutting out the dead tissue and grafting. For partial thickness burns, you try to save viable tissue. Healing relies on surviving skin cells migrating and dividing.
How does HBO fit into burn care?
The idea is it can help reverse the early blockage of small vessels, capillary stasis, reduce tissue drying, and get more oxygen to damaged but potentially salvageable cells.
Does the evidence support this?
Animal studies generally show faster healing, better revascularization, faster skin regrowth with HBO. Studies in rats showed reduced edema, restored cellular energy levels, less waste product buildup. Human studies, including a randomized controlled trial, concluded that HBO within the first 24 hours significantly reduces healing time, morbidity, and even mortality.
Is it used routinely?
It's considered an adjunct to good standard burn care, usually in specialized centers. Protocols often involve early and repeated HBO sessions, maybe 2 to 2.5 ATA, sometimes guided by tissue oxygen monitoring. Reports show benefits like reduced fluid needs, shorter healing times, fewer complications, shorter hospital stays, and lower mortality, especially in high-risk patients or those with larger burns.
So UHMS approves it for burns too?
Yes, for treatment in approved facilities following specific protocols, often 2 ATA 90 mins twice daily. Studies have even shown significant reductions in hospital stay and overall costs when HBO is added to burn care.
What's the list of proposed benefits for burns? Table 16.5 in the source.
Let's see. Counteracting vasodilation and fluid leak, relieving bowel issues post-burn, inhibiting infection, promoting skin regrowth, aiding graft flap survival, helping with associated issues like CO poisoning, reducing hospitalization fluid need surgery, and generally counteracting ischemia to maintain wound integrity.
Quite a list. Okay, finally, let's quickly touch on some specific dermatology applications beyond general wounds.
Right. There's necrobiosis lipoidica diabeticorum, a tricky diabetic skin condition prone to ulcers. HBO has helped in case reports, likely by improving microangiopathy and hypoxia.
What else?
Cuderma gangrenosum, nasty, painful, spreading ulcers, often misdiagnosed. HBO has been used successfully, sometimes to prep for grafting or with other therapies. Purpura fulminans, a severe clotting disorder, often in kids. HBO used alongside standard care has helped in reported cases. Toxic epidermal necrolysis, a severe skin reaction. HBO seemed to help skin regrow in some patients.
Even psoriasis.
Some reports suggest improvement with HBO, maybe via anti-inflammatory or immune effects, but definitely needs more study.
Right.
And scleroderma, which causes skin hardening and often finger-toe ulcers. Small studies and case reports show HBO improving circulation and healing some of these very difficult ulcers, guided by oximetry.
Wow, it really is being explored across a wide spectrum.
It really is. This deep dive certainly shows the diverse applications, backed by a growing, though sometimes still developing, medical understanding.
So wrapping up, it's clear HBO has potential. But as we've heard, it's often an adjunct therapy. It's not a magic bullet.
Absolutely. The decision needs careful consideration of the individual patient, the specific condition, the existing evidence, and integration with standard care.
But it is fascinating to see the surprising ways just delivering more oxygen under pressure can influence healing and tissue health.
It really is.
So, a final thought for you, our listener. We've talked a lot about delivering oxygen more effectively. Given the ongoing research and the varied results, what might the future hold? Could we see even more precise, targeted ways to manipulate oxygen levels for therapeutic benefit, maybe even beyond the conditions we discussed today?
That's a great question to ponder. It's certainly a field that continues to evolve. We definitely encourage you to look deeper into any of these conditions that interest you and the research behind them. There's always more to learn.